So I'm really excited about today's Palliative Care ECHO. I think it's long overdue. We've really tried to talk the talk of that palliative care is an interdisciplinary practice. We pay attention to not just the medical, but the psychosocial aspects and spiritual aspects of our practice. And today we're actually walking the walk by having Sarah McGill and James DeAndrea here talking about setting professional boundaries. So we're going to talk about defining professional boundaries and understand their impact on our practice and how we can assess our own behavior to determine if we might be crossing a professional boundary. We're going to learn about the difference between crossing a boundary and a boundary violation, and then how to effectively establish boundaries by assertively communicating. And Dr. DeAndrea is also going to talk about 2 communication rules of thumb in order to communicate collaboratively. And then we're going to go over a really quick and easy and fantastic resource to advance your practice in palliative care. So without further ado, Sarah.
Hello again. As I said, I'm Sarah McGill, but with full disclosure, I have to tell you that in my former life as a hospice social worker, I was known as the boundaries queen. I feel that it's so important for us to be aware of our professional boundaries, and in doing that, we have to be aware of our own motivations for why we do this work. And we always need to practice within professional boundaries because those boundaries serve to establish and maintain a trusting provider and patient relationship. And they help clinicians maintain justice and equity in dealing with all of their patients, not only a special few. Next slide, please. And just as if you're thinking that Doctors Without Borders, there are Doctors Without Boundaries, but I don't think any of them are on this presentation today. So we work with people of all walks of life in hospice and palliative care, and it is inevitable that we're going to encounter people that challenge our professional boundaries. It might be because the people are really terrific and we'd love to get to know them better, or it might be that we encounter people whose boundaries are already very fluid or even non-existent. This might be because of mental illness, substance abuse. It could be part of that family's culture, or we are working with people who are in the middle of a crisis. And we know that in crisis, our normal coping mechanisms and boundaries are often eliminated or challenged. So it is really important that we are consistent from the very beginning of our relationship with a patient or family about boundaries. It's not always apparent whether someone has good boundaries or very fluid boundaries. And so we have to maintain our professional boundaries in order to protect them and to protect ourselves. Next slide, please. So Elizabeth Kubler-Ross recognizes that professionals in the hospice and palliative care industry are full of empathy. And she says there is within each one of us a potential for goodness beyond our imagining, for giving which seeks no reward, for listening without judgment, and for loving unconditionally. We are all just normal human beings, and we can find it very intoxicating when someone needs us or really likes us. And so we want to be our authentic, empathetic selves. And today we're going to talk about ways that we can keep that professional boundaries in check. So when we do compromise boundaries, we can really put the therapeutic relationship with our patients and families at risk. And this is when they need us the most. And they don't need us as their best friends or their confidants. They need our clinical expertise to get through a very difficult situation. Also, when we cross boundaries, that can be a violation of our company policies and our professional ethics, as well as our professional license. And then when we enter into relationships with patients and families that are more than clinical, we can contribute to our own burnout and compassion fatigue. So that's why I think it's so important to establish and maintain boundaries. This presentation is only an hour, and I can talk about this for hours. And so I thought about what I wanted to offer you today, and that are some simple ways to establish and maintain good professional boundaries while also being able to be that empathetic person who wants to give, to listen, and to love unconditionally. One of the easiest ways to establish boundaries is to start from the very beginning and clearly state your role with the patient and family from your very first visit. Remember that many of these patients and families have never encountered this discipline called hospice and palliative care. And we're more than just friendly visitors, but we're often going into their homes or going into their hospital rooms and seeing them in situations that have very little structure. And so we have to create that structure by explaining what our role is. We want to define what we can do for them when we're seeing them and how you're going to accomplish that, and set some very clear goals for each visit. And each time you see the patient and family, you want to communicate that plan and also report on any progress in achieving those goals. I want to go over a case with you, and we're going to talk a little bit about, in the next section, we'll talk a little bit about ways that we have to check our boundaries at the door. I'm going to give you a little self-assessment. But in doing that, I want to talk about Mary Jo, or MJ, who is a hospice RN. She has been having visits with Mr. Olds, who is an 85-year-old COPD patient, and his wife. And they are just lovely people. She really likes them, and she's enjoying going into their home. They're very happy to see her and receptive to the information that she brings them and the help that she provides. And Mary Jo can see that they do not have a whole lot of support. They have no children, there are no close neighbors. And Mrs. Olds is saying that she can't even get out to the grocery store because she's so tied down to taking care of her husband. And MJ says to them, well, give me a list and I'll go to the grocery store for you. She also tells Mrs. Olds that she only lives a mile away and can come over very quickly if anything happens to Mr. Olds and he has a change in condition. And she gives Mrs. Olds her home phone number. 2 days later, Mrs. Olds calls at 10 p.m. because Mr. Olds is really agitated. MJ can't leave her kids at home alone, so she piles them into the car and off they go with her. While she's in attending to Mr. Olds, the kids are sitting in the living room and Mrs. Olds is making them some hot chocolate. A few days later, MJ goes shopping for Mrs. Olds and refuses to accept payment from Mrs. Olds when she brings her the groceries that she purchased. Mrs. Olds is very uncomfortable about this, but she says nothing because, after all, MJ is her nurse, she works for hospice. Maybe this is something she's supposed to do as part of her job with hospice. So think about that just a little bit. All right. As I stated before, when we cross boundaries, we put ourselves at risk for compassion fatigue and for professional burnout. We risk getting into situations that we often do not know how to get out of. And we get into situations that put our jobs at risk. Therefore, I find it very useful to have questions that you can ask yourself when you feel like your professional boundaries may be compromised. So let's think about MJ as we go over this self-assessment. So one of the first questions is, ask yourself, what is my company's policy about this situation? And what are the regulations of my professional license and my professional code of ethics? I think it's pretty safe to say that in whatever setting MJ works in, whether she's in a hospital or a home hospice, the company's policy probably prohibits bringing your children into the home. You can imagine the many complications that could arise from introducing your children into a strange home. Then another question that I always want to ask myself is, am I maintaining a policy for absolute confidentiality? And certainly by introducing your children into a home setting, for instance, you are violating that patient and family's confidentiality, because you can't guarantee that your children aren't going to school with their grandchildren and maybe talking about their experience. We actually had an experience where a nurse brought their children into the home, and the children were really upset about what they saw and talked about it with their teacher at school. And the teacher called the nurse and said, your children were talking about, you know, your work. And that caused quite a ripple effect. And this nurse was reprimanded for her behavior. This is my favorite question, and I think this is probably the one that gives me the most pause, is, can I tell my team about what happened? And if I do tell them about bringing my kids to the patient's house at 10 o'clock at night because the wife called me on my home phone number, what is my team going to react? How are they going to react? Am I going to encounter dead silence? Shocked expressions? Well, if you were telling me that, I guarantee you, you would see the shock on my face. And there's lots of things that we're going to encounter with our patients and their families. And we may have to ask ourselves, is this something I can tell my supervisor about, that I can share with my team, that I can encourage others to do? That's a test of your boundaries. Next slide, please. Another question to ask, is this something that I can do with all of my patients? Now, some caseloads are smaller than others, but I would say that the average caseload of a hospice nurse would be about 15 to 20 patients, give or take, 10 on either side, depending on how big your hospice is. Could a nurse really grocery shop for all of her patients if they needed that? So you want to ask yourself, can I do this for all of my patients? And then, as we do work with a team, and there are other nurses that are going to come in and see this patient, will everyone coming after me be able to maintain the expectations I have set with this family? And I can hear an echo of, oh, hell no, from a lot of people out there, because they don't want to overstep their boundaries and get involved in things that they have not the time to do. We know as hospice and palliative care professionals, we're very, very busy. And if we step outside of our lane and take on more responsibilities, something's going to give. And then, is this patient and family member worried about me talking about my life? Is this patient and family worried about me, or are they talking about my life more than his or hers? It's almost impossible to connect with another human being without sharing something personal, especially because we have to develop trust to talk about difficult issues of death and dying. And so, of course, our families are going to ask us, are you married? Do you have any children? How long have you been working here? Where are you from? Those are typical things that people are going to ask us. But if we reply with, oh, I've been working for hospice for 15 years and it's gotten to be a nightmare. I am so exhausted all the time because I'm constantly running from one thing to the next. Patients and their families start to worry about you, and then they start asking you on subsequent visits, how are you doing? Has it been busy? What's going on with you? The best thing to do is to turn questions back to the patient and to the family. So if somebody asks you, for instance, where are you from? Well, I'm from Florida, and I was born and raised there, and I've lived in Nevada now for about 6 years. Tell me about you, Mr. Smith. Where are you from? Oh, tell me more about your life in Colorado. Did you live in the mountains? Did you ski? Tell me more about that. So that keeps the focus off of you, and then again allows that patient and family to do that self-review that is so critical at the end of life. Next slide, please. Another assessment is to ask yourself, am I working inside my scope of practice? Or am I trying to solve issues outside of the responsibility of not only my discipline, but even sometimes hospice and palliative care? I recall back in the first economic crash that we had in mid-2000s, where families were asking us to write letters to their mortgage companies because they were in default on their mortgage. And it had nothing to do with the fact that they were in hospice. So sometimes you have to set some boundaries there in what they ask. But are you remembering that you have a team that works with you? We all have different roles on the team, and maybe it would have been more appropriate to have MJ say to the olds, we have volunteers that would be glad to go grocery shopping for you. And then, do you feel overwhelmed, overworked? Do you feel resentful of your patient's demands? Do you find yourself trying to avoid seeing a particular patient, maybe, asking someone else to go see them because you have a sense of dread that they're going to ask you to do something that you don't want to do? Do you wish that you'd never started doing whatever it is because you don't know how to stop and how to set that limit? And are you spending more time with or worrying about your patients than you do for yourself or your family? It's very likely that MJ could be at a baseball game with her son and get a call on her personal phone from Mrs. Olds asking her to please come right away. She hasn't established the boundaries and the appropriate people to call after hours. And so MJ gets caught up in that. And pretty soon she's going to start resenting that. And she's also not spending that time with her family. So these are the kinds of things that I want you to think about as we discuss boundaries. There could be a whole other presentation on social media and our professional boundaries. Many times we're asked if we're on Facebook. I have had patients find me on Facebook because I don't have really tight privacy restrictions. And next thing you know, I've got someone that I feel very uncomfortable with asking to be my friend on Facebook. And I feel guilty about having to say no. But I know that I set very strong boundaries that I don't want to cross. I don't want everyone knowing my business that I post on Facebook. And I don't necessarily want to know some of the things that other families post on Facebook. And I just want to also quickly mention that in this age of the internet access, we can Google people and we can find out all kinds of information about them. And I think that it is very unethical to do that. I've had situations where fellow social workers were routinely Googling family members to see if they had any criminal backgrounds, and looking into things that had no influence on the relationship that the social worker had with the patient and the immediate family that she was dealing with. And so we really need to check our boundaries about when we have all kinds of information available to us and make sure that we're not overstepping. So now I'm going to turn this over to James DeAndrea, who's going to talk to you a little bit more about some communication skills that can help you if you find yourself in difficult situations.
Okay, so I saw that there was a question in the chat box about being a country doctor and having to do some things that that entails, and whether that represents a boundary violation. So, you know, sometimes we may need to bend the rules to preserve the therapeutic relationship. However, ethical codes warn of the dangers of creating dual relationships that violate boundaries. Speaking as a psychologist, the American Psychological Association recognizes that dual relationships are sometimes unavoidable. For example, if you live in a rural area, you may have a dual relationship with someone in your community simply because it's unavoidable. Maybe they own a store and you do your shopping there, or maybe you were driving too fast through town and someone you're working with is a police officer who did not know it was you and pulls you over for a speeding citation. These dual relationships are unavoidable, but that doesn't give us permission to engage in them, and many ethical codes recommend that dual relationships should be avoided whenever possible. So how do you know the difference between when you're engaging in a boundary crossing versus a boundary violation? Well, I put up here a table to help you to recognize the difference. Boundary crossings are benign, and they can even be helpful breaks in the therapeutic frame. So if you're going into someone's home and they invite you to sit down for a cup of tea and have some conversation, that's not necessarily a boundary violation, but it is a crossing of that professional boundary, and it turns the relationship for that moment into more of a social one. Boundary crossings usually occur in isolation. These are not patterns of behavior that occur. These are kinds of one-off things that happen. They're minor and attenuated. They are generally not big things. And you can talk about them. They're discussable. So in the example that Sarah gave, Mrs. Olds felt uncomfortable that MJ was rejecting her reimbursement, but it was up to at that point, you know, Mrs. Olds to speak about it. You know, that was she was being very passive there. But sometimes these boundary crossings are not taboo subjects. You can talk about them. And ultimately, minor boundary crossings don't cause any harm to the patient, to the clinician, or to the treatment that you're providing. On the other hand, boundary violations are much more severe, and they can actually be exploitive breaks in the therapeutic frame. And these turn into patterns of behavior that one or both people are uncomfortable with. Boundary violations can be egregious and extreme. So some examples of egregious and extreme boundary crossings would be entering into a financial relationship with someone that we're working with, or even getting romantically or sexually involved. Those would be egregious and extreme examples. These are not things that clinicians feel comfortable talking about, and clinicians will actually discourage discussion about them and say to the family or the person they're working with, please don't report this or tell this to my supervisor because I'll lose my job. That's a big red flag. And typically, these boundary violations will result in harm to the patient, harm to the clinician, and ultimately compromised treatment. Okay. Next question. Sorry, next slide. So, effective communication is the foundation for establishing appropriate boundaries. And what I've put up here is a framework for understanding different communication patterns. These communication patterns exist along a continuum, so we move back and forth between them. And I'll cover each of them. And as I do, I'd like you to think about what kind of communication pattern you tend to use or feel most comfortable with, and with whom. Okay. So next slide, please. So the first style of communication pattern that exists at an extreme is passive communication pattern, is being passive. And this is where we place the other person's needs ahead of our own, and our own needs become secondary. And people who engage in passive communication often have a desire to be liked, and their goal is to avoid conflict at all costs. By engaging in passive communication, the person implicitly creates a contract that says, if I satisfy your needs, then when I need something from you, I should get it. And it's a very subtle form of manipulation. Over time, resentment builds because the relationship becomes stilted and one way. The person who is passive always feels like they're giving in, and they don't feel like their needs are being recognized or addressed in any circumstance. So there's this lose-win dynamic that sets up that creates the resentment. So in the example that Sarah gave, MJ allowed Mrs. Oles' needs to be placed ahead of her own. She allowed Mrs. Oles to call on her personal phone at night and to put her kids in the car and go shopping for her. And MJ did not speak up and attempt to establish a boundary and was being very passive in that situation. In other situations within hospice, we can encounter someone who says, I don't know what to do. I guess I'll do whatever you think is best, right? And so that situation is not ideal. It's not patient-centered, and it puts us in a very uncomfortable situation. Okay, next slide. At the other extreme is aggressive communication. And this is when people communicate in such a way where they believe that only their needs matter. And they'll meet your needs if only they don't have to give up anything or it doesn't convenience them in any way. And the mentality is that the relationship is a zero-sum game. The person thinks that I gain only at others' expense. Unlike the person who communicates passively, they don't worry about creating conflict. And in fact, conflict could be a means to an end and be used to manipulate through intimidation. And so there's a win-lose dynamic that is set up and created. It always feels like, gee, you know, what I need to do or what's important to me is not being addressed or acknowledged in any way because this person is steamrolling me. It might seem like a winning strategy initially, but the person who communicates aggressively over time starts to become isolated because no one wants to deal with a person who is aggressive all of the time. It's very difficult to collaborate with someone who's aggressive. They're not willing to budge an inch and can become intimidating if you don't give them what they want. So for example, a family member may want you to initiate an inappropriate treatment or withhold a treatment that would be beneficial. If you don't do what they say, they'll threaten to report you to a supervisor, as an example. Okay. Next slide. So if you go back, if you remember from that, that continuum of communication that I showed you earlier, there's a whole middle area in between being passive and being aggressive called being assertive. That middle area that's called assertion comes from the psychological literature. And I prefer not to use the term assertive because it connotes being aggressive. It's often not complimentary either when you're referring to another person to call them assertive, because what you're implying is that they're really aggressive. So what I like to use instead is to use the word collaborative. When we're communicating in a collaborative manner, we're trying to meet the needs of the other person as well as meeting our own needs. And collaborations involve give and take. Each person may not feel like they got everything they wanted or needed when engaging in collaboration, but at the end of the day, each person feels like they got enough. Collaborations or negotiations may take time. So for example, you know, if you're in a committed relationship, you know that you're constantly working on collaborating and negotiating. Okay, it's not something that just happens discreetly. It doesn't just happen all at once. It takes time. And you have to agree on a small compromise and revisit later when circumstances change. The idea here is that you're trying to create a win-win dynamic, but this is much easier said than done. Okay? Collaborations take time, they can be difficult, and sometimes when there's when we're engaging in a collaborative relationship, it might seem like we're getting nowhere at times. And at times there might not be a solution at that one point. But it's important that we commit to not giving up and come back and revisit the situation later when circumstances change or when we get more information. Okay, next slide. Now, one of the unique communication styles that I want to talk about is called passive-aggressive communication. And this combines the worst of both ineffective communication styles and puts them together. Outwardly, a person who is passive-aggressive verbally expresses passivity or cooperativeness, but they indirectly behave in an aggressive manner. So there's really nothing passive, I don't think, about someone who is, you know, engaging in passive-aggressive communication. What they're really doing is they're hiding their aggression behind this veil of passivity. And it's an ineffective means of communication because no one's needs gets met, because a passive-aggressive person is not dealing with the issues honestly and directly. And so over time, resentment builds in both parties, and it sets up a lose-lose dynamic. So for example, you see a patient while the caregiver seems to approve of your care and smiles when they see you, but then they do things to sabotage your efforts. That's the passive, you know, that is the passive part where they outwardly seem like they're happy with you. but then behind your back, they call your supervisor without talking to you and criticize you and complain about the care you provide and insist that you be removed without talking directly to the person, so or to the provider. So there's this aggressive style there behind the passivity. Okay, next slide, please. So how do you increase your ability to collaborate with someone? Well, I've given you some rules here, rules of thumb for good collaboration. And the first rule is to remember to be persistent. That's rule number one. It's important to be persistent and not give up on the relationship. If a person complains about the care that you provide them, you can use a technique called the broken record technique. So for example, in the situation with MJ and Mrs. Oles calls up MJ in the middle of the night. And MJ can say, well, I don't work in my on my off hours. And Mrs. Oles comes back and says, well, but I really, really need help right now. And then you can simply repeat again, I don't work on my off hours. So you just sound like a broken record. You don't change the words you're saying. You don't change your tone of voice. Just like a broken record, you keep on repeating the same message over and over again, and they will get the message eventually. Another rule of thumb is to listen for free information and then follow up with relevant self-disclosure by using I statements. So if Mrs. Oles, for example, says, you know, I feel so isolated being a caregiver. I never expected that taking care of my husband would be so draining on me. You can follow up with that free information from Mrs. Oles by saying something like, when I took care of my mother with dementia at home, I felt alone and angry that my life came to a stop. But it was also hard to accept because I didn't think anyone could but it was also hard to accept help from anyone because I didn't think anyone could take care of her as well as I could. Okay, and so that deepens the bond between you and the person that you're working with to deepen that level of collaboration by disclosing appropriate information. Another technique that you can use to enhance collaboration is to use conditional statements, such as, if I, will you? If you, I will. Or let's make a deal to reach a workable compromise. So for example, you could say something, MJ could tell Mrs. Oles, let's make a deal. I'll go shopping for you once a week if you call me during normal working hours. Okay. One of the things to be alert for is to recognize the difference between a complaint and a criticism. It's okay for caregivers to lodge complaints about the care you provide, but you also have to be aware of the difference between a complaint and a criticism. A criticism is ascribing a complaint to a personal characteristic of yours. So if a person says, you know, you're not a caring person, when they're really upset with something that you're doing to their loved one, that's a criticism. But if they said something like, well, you know, you're being too rough with my husband, that's a complaint, and that's valid and legitimate. It's not attacking the person, it's just complaining, making a complaint, a legitimate, valid complaint about what you're doing. So how do you deal with criticism? Well, you can use a technique called fogging. And fogging involves agreeing with the truth that the person is reporting just in terms of the principle. So an example of fogging in this case would be saying, you're right, sometimes I forget how strong I am. I will keep that in mind whenever I'm working with your husband. So you're like, it's called fogging because they might be punching at you, but you're going to act like a fog bank. And when you imagine punching a fog bank, you're not really hitting anything, right? So that's the idea of fogging. You're just going to agree with that little kernel of truth in what they're criticizing, but you're not agreeing entirely with it. Let's see, there's something in the chat box here. Oh, okay. All right, so I do not have anything else here to present, and I'll let Dr. Conright talk about her piece here.
Troy, I was hoping that you could allow me to share my screen.
Yeah, so go ahead and pull up that website in the background and then go back to Zoom and hit that green share screen button.
Okay.
There we go.
Hey, it's working, yay. 1 second here. So I think I'd just like to round this presentation up with sharing a resource. Part of our mission or our aim for our Palliative Care ECHO is to really enable our audience to go forth and practice, elements of palliative care. We're sharing topics with you, but we also want to be a source of education and resources. And I'm about to share one of my favorite resources that is this is an application that you can download on your phone. Or just a quick internet search. It's the Palliative Care Network of Wisconsin, PC Now. And the app that you would download is called Fast Facts. And this is a fantastic, wonderful resource that you could just pull up and in a couple of minutes find information relevant to the field of palliative and hospice medicine that you could use right away and work with. And what I'd like to demonstrate today in this resource, so this is a website, as you enter it, and the link is in the slide that was shown. This is the Palliative, as I said, the Palliative Care Network of Wisconsin, and I'm going to go to Fast Facts and click on Fast Facts. And if you wanted to know something about, I'm already on the Fast Facts. If you could read through, there's over 400 Fast Facts that exist right now, on topics. You can see some of the topics right here, diagnosis and treatment of terminal delirium, morphine and hastened death, delivering bad news. But if you wanted to search a topic, I'm going to type in boundaries, because today we've been talking about professional boundaries. And right here, lo and behold, is professional patient boundaries. And I'll just, quickly go over this screen to show you how brief it is. It gives some background and causes of boundary problems that Sarah spoke about, psychiatric disorders, cultural misunderstandings. Here's some examples, giving, gift giving to patients and families, patients having or wanting access to a provider's home phone number. Here's tips to self-monitor whether a boundary issue might be happening. And these points here, Sarah went over, and then how to manage boundary concerns. And you can see how very brief and easy this is. There's topics here on the management of diabetes at the end of life, based on whether a person might have weeks of life, days of life left, or months of life. I'm gonna go back and something that I hadn't planned before today, but I'm just gonna go ahead and do this. And it is a bit of a brag here, but our very own on this call, Dr. Laws, wrote up a fast fact and published this herself: cancer-related incident bone pain. Again, this is a brag, but this is really helpful point of care information that you could access quickly. So I really encourage everyone on this call to check this out and use this to inform your practice in palliative care. And I'd like to go back to our slideshow right now. I can stop screen sharing. And Troy, let's see here. Aha, this, Sarah, maybe you could just briefly speak about this as another resource for our audience.
Yes, if you're interested in learning more about your own discipline's professional ethics and how that's related to boundaries, then I've put up the websites for a number of the typical disciplines in hospice and palliative care.
All right, thank you so much, Sarah and Dr. DeAndrea. So we'll open it up right now for questions from the group. Feel free to unmute yourselves or write them through the chat box, please. Anything out there you'd like to ask the presenters today? Feel free to chime in, please. Dr. Bayan is saying, I see the line between boundary crossing versus violation can often be murky or not well defined, but subjective to social norms of a particular period in time. Are standards different in different places?
I'd like to answer that question. I think that yes, the standards are different the standards are the same in terms of our professional ethics and restrictions via our license and by our agencies that we work for. But social norms are going to be different in different places. And I come from the South, and it was not uncommon at all for families to anticipate our visits and have something prepared for us. I also worked in a Cuban population, and you know, it's rude to refuse a cup of Cuban coffee from the person who's offering it to you, and I didn't drink coffee at the time, and I would have to go into this explanation about, oh, that's so nice and it smells so good, but I don't drink coffee and I'll just be jittery all day. And then other nurses would come back to the office and they'd be all jittery, and you knew where the patients they'd been seeing. So, and here I find that that the social norms are a little bit different. In the South, it's not unusual for any member of the team to feel comfortable praying with the family or talking about their spirituality. Here, for lack of a better word, the rugged individualists that live in Nevada often, aren't as demonstrative about their spirituality. And so I found that, I have to get permission in a different way than I have before. I hope that answered your question, but there are definitely social norms that you have to be aware of wherever you are, wherever you're working.
And I would like to add that professional norms also vary. For example, mental health workers are very careful about disclosing any kind of personal information. And I find that those boundaries are a lot tighter than what I hear that are from more medically oriented providers. So for example, if I'm walking down the hallway in the hospital, it's not that unusual for me to hear a group of doctors talking about a medical case. But certainly you wouldn't want to hear a mental health provider disclosing any discussing any personal information about something that a patient related to them in therapy and overhear that in the hallway. So even within healthcare, I see that norms vary.